Then we are going to begin first with a tiny literature review because this is the beginning of the proposal of a multi-center study, and then think it's important to begin with the scientific basis and histological basis. Then this is the topics that we are going to talk. The first one is the importance of the intimate contact between implant and the bone at the receiving site versus the surface treatment. I love this study made by Stroman when Stroman likes to promote its SLA surface. But there are a lot of things that we could found in this study. We are going to discuss the surface versus the final drill importance. And as you can see, only the tips of the threads are contacting at the bone. That means that the final drill was wider, and we don't have an intimate contact between the threads and the old bone. As we can see at the day 4 at this really nice histological study, the old bone resorbs and decrease the total stability. That means that at the beginning, the stability depends of the contact between the threads and the old bone. I love these topics who Dr. Davis talked about the contact osteogenesis and the distance osteogenesis. That means the contact osteogenesis is the direct bone formation made by the intimate contact between the clot and the implant osteoconductive surface. That means, as we already talked in the first session, the importance of the passive but intimate contact between the threads and at the bone. And with the evolution of the surface, they are trying to increase the distance of osteogenesis. That means bone growth from the native implant to the implant surface. That means the needs to the old bone of the native bone grows to go into the implant surface. Then in the evolution of the surface, they are looking for as SLA surface, an osteoconductive surface that lets the clot be in intimate contact with the surface and then begin the process directly to the bone. But in this case, we lost the importance of the intimate contact and the final drill protocol who let us to have intimate contact between the threads and the native bone. That's why Neobiotech enables the passive jet but intimate fit between the implant and the bone, as Dr. Cabrera says and Dr. Alves too. The importance to personalize the protocol drilling to the patient and the kind of bone that we are working on it. Mainly on the old bone made by cortical bone. It's really important to the cortical tapping in order to get this intimate anchorage. Okay? Then we are going to talk about the stability dip and the relation of the final bone implant contact. Dr. Platz explained that perfectly. And maybe at the end, when we get the total stability, there are no big difference between any protocols, but we are looking for have no stability dip performing intimate contact between the threads and the native bone. Okay? Now we are going to talk about the relation between surgical protocol and the result of histological findings. In this study, I think it's a study who reviewed at 10 months after implant placement in a human histological Neobiotech implants following the drilling protocol. And as we can see, there are a really nice formation of the native bone that surrounds the implant. Dr. Cabrera talked about this study and increase the bone implant contact. Obviously, we are looking for a histological study where we can observing the bone reaction at day 0, 4, and the week 1, 2, and 4 weeks that, as we already talked and discussed, is really important in order to avoid this stability dip, and the final result in order to increase the disintegration. Okay? Then we are going to review this article. In this article, we have two, we could compare two implants in histological findings, Neobiotech and Cotec implants. And I love this view because, as already see at the Neobiotech implants, we have a really nice contact. But here, maybe you can see it at the Cotec implant. Let me show you here. Here, looks like, okay. There are a kind of new bone formation between the implant and the threads, because the final drill was parallel and it's not don't let have an intimate contact between the threads and the bone formation. The final result, I think, because the drilling protocol was that Neobiotech implant has a really nice, more than 70% of bone implant contact, and when they use a different drilling protocol, they don't have a really nice bone implant contact. Okay. Then, absolutely, we need the histological studies. I know that it's difficult because we need maybe a model study or something, but maybe we could looking for more a clinical study, maybe with any check that we could use in a really easy way to do a multi-center study in our practice, in our normal clinical practice. Okay, then we could go ahead with the discussion.
Thank you, Dr. Feregrino. It's now time for discussion.
Doctor, can you hear me?
Yes.
Yes.
Thank you for your nice presentation, very objective. From your point of view, how do macro and micro design features of the implant have an effect on bone healing and bone formation?
Okay, micro design could be the surface, or maybe a kind of nano design, and then we could rest in SLA surface that promotes the contact osteogenesis, and it's really nice. About the macro, I think if we have, as Neobiotech system has a relation between the cortical tapping and let us have an intimate contact with the threads, we could promote the contact and the distant osteogenesis between them, yeah, because we are working to get a passive but intimate contact between the implant and the bone.
And I have a second question. Regarding the existing studies, what are the limitations and the knowledge gaps that we still need to address in the future?
Yeah. Yeah. Well, first we have to try to as less as possible, but have an intimate contact. Yeah. It's impossible to have too much contact between the implant and the bone because we could perform too much pressure. But if we have a passive contact, we let the clot to conform the natural way to the osseointegration. But the importance, maybe when we are working at the cortical level, is the physical structure that let us to promote in a dynamic force the osteogenesis. That means when we got a good immediate loading that doesn't have a continuous pressure but a biting normal pressure, that means a dynamic pressure to the bone that promotes the osseointegration. This is Brannemer explains perfectly when he talked about the Frost law, that the dynamic forces at the bone promotes the bone formation. Then I think with the drilling protocol we have the best of the two worlds. That means the micro design, that is the surface that promotes obviously the osteoconductive properties, and the physical structure to maintain the intimate contact between the threads and the native or old bone, whatever you said.
Okay, Manuel. Good presentation. Can I see the study, to show the Straumann study? Okay, okay, that's it. When you see the arrow, the bone loss, so this is after 1 week or 2 weeks, because the first time when the implant is placed, it should contact, okay, with the old bone. But after 1 week or 2 weeks, the old bone is resolved, right?
Yep.
And there's a space. So that's why the stability dip is occur, right? The old bone is contact to the bone, contact to the implant. Maybe it's because of the bone trauma from the overcompression and overheating, right?
Yep.
And then the body resolved the old bone, as you see there. Then after 1 or 2 weeks, then repair to the with the new bone, and the increase of total stability, right?
Yep.
So we focus on that, okay? Because we need the old bone contact for the initial stability. But after 1 week, we don't want to get decreased, stability decreased.
Yeah.
So if we have a high contact, high pressure contact to the old bone, it will be very largely decreased. Bone is observed, resolved. So and they show the distance osteogenesis, but that's okay. But it's only a little contact to the point of the thread. That's not enough for loading before osteointegration, get osteointegration, right?
Absolutely.
Because when you load the implant in that narrow contact area, that cause of the overcompression to the bone, and it causes bone loss. So we need more bone contact, the maximum contact to the bone, BIC, for the loading. But the difficulty is how we get intimate contact without bone trauma. That's the most important things, right? But we try to eliminate the old bone resorption by minimizing the bone trauma, okay? But the question is, how do we get that? That's the very important things, right? By something what? Right? By self-tapping?
Yes.
But that's not the ideal fixation, right? So maybe we need a pre-tapping on the hard bone, right? And still we get intimate contacts. So when you have the pre-tapping with narrow drilling first, and then pre-tapping, finally we get good passive contact to the old bone, then minimize the bone trauma.
Yeah. Yeah.
Do you agree with that?
Absolutely. The concept is old and new, because if you remember the first kit of Brannemar system,
Right.
we pre-tapping a lot of for our implants in a D1 implant.
Right.
Then after that, the companies try to find an easy protocol for drilling. And then we forgot the importance of pre-tapping until now. Thank you for you, because we said, okay, the surface is really important. Every of us know it and recognize that. But now we have to return to a D1 pre-tapping as all days in order to get, as you said, a passive contact, but intimate contact, yeah, in order to preserve this
Yeah.
old bone. Yeah.
So how can you get pre-tapping on pre-tap? I mean, step tapping on the D1 bone with the narrow drilling? It's almost impossible.
Yeah.
So sometimes we destroy the surface, actually surface,
Yeah.
beautiful surface. We destroy it.
Yeah.
So the two things, we get good fixation, but passive contact, and maximum BIC for the immediate loading or early loading.
Sure.
So how we get that condition is a very important thing, right? So the solution is how do we manage that for the D1 bone? Maybe we need a pre-tapping, right?
Absolutely. Yeah.
Which most of dentists doesn't like it.
Yeah. Yeah, because we are looking for a easy drilling protocol, but we sometimes forgot
Yeah.
the importance to personalize the drilling to the patient.
So for the D1 bone, for the self-tapping, we need a large drilling, as you show that, because we have a big space between implant and the bone, right?
Yep.
But that's not good for anytime loading, right?
Yep.
Thank you.
Yeah, that's good.
The allocated time for discussion is over, so I think it'll be great if Dr. Moncol can pick it up from there.